So thank you for inviting me to participate in the Renal Research Institute 2021 meeting. And my task over the next short while is to help perhaps put in context the future of nephrology and some challenges that we have in terms of caring for people with chronic kidney diseases. This is my disclosure slide, but as you know, I always put in perspectives because I believe that as a clinician, administrator, and researcher, my disclosure are as much my perspectives and really influence the way that I present this conversation and hopefully open up the conversation for others. So my goals are to give people a sense of the global health and current status of chronic kidney diseases, to think about chronic kidney disease as a global public health problem, but really as a paradigm for complex care models, and look at the opportunities that are before us with respect to care, research, and policy. But mostly what I want to do is hopefully stimulate discussion. And I appreciate that in a world where we are all virtual, that discussion may have to take place over multiple different venues, but hopefully it will continue long after this call. So chronic kidney disease is a growing public health problem. This is a slide from the Global Burden of Disease showing that we've had the dubious honor of going from number 25 in 1990 up to 17 in 2015. And more recently in 2017, we were number 16, and we're expected to be number 5 by 2040. Not sure that this is a wonderful thing, but perhaps it sheds a spotlight. Importantly, chronic kidney disease as a disability attributable life year problem actually accounts for 1.35% of the total DALYs and is growing at an annual rate of about 1%. Worldwide, there are 850 million people who have some form of kidney disease, and I'll remind this audience that the population of Europe is 750 million. Hence, there are a lot of people with chronic kidney diseases. And from a global perspective, it's important that we remember that it's common, harmful, and treatable. And whilst it's linked to other non-communicable diseases such as diabetes, hypertension, and cardiovascular disease, it also, as you know, can be inherited and has other causes. But there's a huge variation, and I'll highlight some of this in the approaches, resources, and policies that exist between and within countries and regions. There's a diversity of kidney diseases, be they acute or chronic. And I think we need to be careful and acknowledge the role of healthcare systems and the multiple partners that are there to prevent and control chronic kidney disease and to integrate national and international NCD management strategies into our approach to chronic kidney diseases. So one of the big reasons that we're here and that we're all interested is that the clinical problem remains access to care, whether that's prevention, delay of progression, or renal replacement therapies. Many of you will have seen this slide, and germane to a dialysis conference is the fact that many people around the world do not receive kidney replacement therapy. And there's an estimate that between 27 and 53% of people who need kidney replacement therapy get it, which actually translates to about 2 to 7 million people who do not. And this, of course, is growing as world health disparities grow. This slide shows the similar thing in other format, which is that by 2030, about 14.5 million people will need kidney replacement therapy, but only less than half of them will actually receive it. And of course, this disparity is different depending on whether you're in a low-income setting or a high-income setting. But I will point out to you that even in high-income settings, people do not necessarily receive kidney replacement therapy. So what are the public health strategies to promote kidney health? Firstly, there's awareness of the burden of disease, and you have to define the problem and identify causes and risk factors. And then generating solutions means that you need to develop and test interventions, and importantly, as we know, implement them. And obviously, one needs to evaluate in practice and redefine the problem and reevaluate over time to make sure that we're getting it right. And when you think about health policies and how they're formulated, they need to be based on data. We can use templates and principles from existing policies. They have to be integrated with other health priorities. And obviously, we have to demonstrate the relative costs and benefits of any strategy or policy that we propose. And interestingly, if one looks at the cost of treatments, I don't know if we've always highlighted to policymakers that identifying high risk and early disease is not very costly, preventing progression is more costly, and dialysis and transplantation are most costly. And I'm not sure that we've taken advantage of this knowledge for us when we're doing and developing policies or advocacy statements. This is a slide I kindly borrowed from Valerie Luxix that describes that end-stage kidney disease imposes chronic catastrophic health expenditures in certain specific locations. In fact, the indirect costs of work loss for patients, relatives, and transportation are massive and not necessarily dialysis specific, but importantly, really does end up costing in India, certainly 91% of people lose their livelihood altogether just because they go on to dialysis. And it's very important that we think about these catastrophic health expenditures when we're trying to advocate for preventative measures. So in the global context, healthcare system delivery systems are really not economically sustainable. 8 to 20% of GDP occurs in the G20 countries. And as we all know, there's an infinite demand for a finite amount of clinical and financial resources. And we really need to manage the public expectations of access to care, as well as what things are costing and how we're doing it. So my thesis is that chronic kidney disease is a complex condition and it coexists with many others, and that we should develop models of care that integrate the complexity of the clinical condition, a patient-centered philosophy, and to also advocate for the fact that we need a healthcare environment that's supportive. I believe that the principles of care are universal and we have to implement customized to specific circumstances. This is a slide that really just kind of looks at complex patients, families, and populations at the center, and looks at all of the different things that need to be looked at in context to really improve outcomes for people. And the chronic care disease model that many of you will be familiar with describes a community with resources, policies, and that are supportive of a chronic care model, a health system that's organized with respect to fit-for-purpose design, decision support, and clinical information systems, as well as the support of patients for self-management. That preparing a proactive practice team and having informed, activated patients leads to productive interactions and ultimately improved outcomes. And most of us would advocate for this, certainly, but we also know it doesn't exist everywhere. We know also that chronic kidney disease is a complex, and there are multiple determinants of disease, be they perinatal and genetic, environmental, educational, and then there's the risk factors that occur over time. We also know that there are variable trajectories of disease that are impacted by intercurrent events, whether they're disease specific or random, and all of this culminates in a burden of disease. Again, this audience is well aware that both acute kidney injury and chronic kidney diseases are global problems, and they're challenging for all of us. That we have a worldwide epidemic of diabetes, which is really increasing exponentially, and with that, most likely an increase in one of the major risk factors for chronic kidney disease. We know that we have international estimates that are quite consistent, that between 10 and 16% of adults have impaired kidney function of some degree, which we know actually portends worse outcomes, not just end-stage kidney disease. That throughout the world, there are variations in this burden, and this may be a data capture or a data testing issue, as I'll show you, but nonetheless makes us take pause. We know that there's variability in the progression of kidney disease. It's not linear. And how do you recognize in any projections the nonlinearity of those trajectories over time that have been well described in multiple publications? We know that if you look at the prevalence of dialysis and different modalities, this slide shows that in 5 European countries, Germany has the lowest prevalence of end-stage kidney disease, highest prevalence, and Italy has the lowest prevalence of end-stage kidney disease. And in Latin America, the uptake of peritoneal dialysis is remarkably different depending on which country you look at. These variabilities actually make it difficult for us to advocate on a global stage. We know that within countries and between countries, geography and race really impacts access to care. And that's whether you're in a socialized healthcare system like Canada and the UK or Australia, or in the US where there is different kinds of healthcare. And so if you think about the variability in care globally, it's in access to prevention and treatment, access to dialysis and transplantation, and even access to trained groups of people and healthcare providers. And the ISN, the International Society of Nephrology, for which I'm humbly the past president from 2015 to 2017, actually described a future where all people have equitable access to sustainable kidney health. And in order to really understand that and be able to actualize that, we actually held a Global Kidney Health Summit, which was published in The Lancet in 2017. And this is where clinicians, researchers, and scientists, as well as industry and others, identified a series of gaps in care, research, and policy. And in three big buckets, we thought it was important to improve identification of kidney disease and reduce the risk factors, improve our understanding of the causes and the consequences, and develop and test new therapeutic strategies. And in that context, we also launched the Global Kidney Health Atlas, which described the states of kidney care according to 6 dimensions of universal health coverage. We used a robust survey methodology, got data from regions and countries, as well as having ongoing data collection. And what we looked at was universal health coverage, where you need healthcare workers, treatment access, medicines, information, health policy, and dollars to fund the system. And looking from those dimensions, we actually were able to describe within the Global Kidney Health Atlas each of these different components. And I'll share with you some highlights of that that may help to make some of what I said earlier in context. So in 2017 and then in 2019, we repeated the GKHA. And what we found was that actually there are workforce shortages around the world of trained nephrologists and the healthcare workers, that globally there's poor chronic kidney disease detection in terms of checking kidney function and well as urinalysis, and poor awareness, that there are very few places that have public funding for kidney care, and that from a policy perspective, there's very low kidney disease priority. There are few national kidney registries or strategies. There's sparse advocacy, whether it's AK or CKD, and many places have not enough research capacity. All that being said, this is some of that data looking at the renal registries, and you'll notice here that whether it's a CKD registry, a dialysis registry, a transplant registry, or an AKI registry, there's huge variability, and really almost nowhere has 100%. Basic testing isn't available. This is a spider plot looking at the availability of blood pressure cuffs, ability to measure serum glucose, A1C, cholesterol, creatinine alone without a GFR or with a GFR, qualitative and quantitative urinalyses or protein measurements or radiology and pathology services. And you can see that there's huge variation by low, middle, and high income countries. Again, if you can't detect a disease, then you certainly can't prevent it. And this is a bit of a summary in terms of the gaps according to World Bank criteria. But importantly, you'll see here that, interestingly, if you're in a low-income country, there's more governmental recognition of CKD as a priority than in a high-income country. And yet there's such a variability in access to other resources. So the paradox in all of this is that if you think about the amount of resources that go in, especially in high-income countries, for the treatment of chronic kidney diseases, there actually isn't as much of an evidence base to inform clinical care. And we really need to address this issue in terms of evidence base. And we are slowly getting there, but our challenge really is to conduct clinical trials worldwide so we can really inform best practices. This is a nice overview by Ike Okpechi and others in South Africa, looking at the representationness or the representativeness of world populations in clinical trials, where most of the world lives in a place that doesn't necessarily allow them into clinical trials. And so I think that's an issue in terms of generalizability. I said before, but I'll repeat again, that the future of nephrology is a better understanding of the complexity of kidney diseases, its multiple profiles, environments, and different time points, but the interaction between environment, lifestyle, and genetics is incredibly important. And we can and should look at large populations to serve as sources for biosampling, phenotyping, and doing not just observational cohort studies, but building those into administrative data sets and then clinical trial involvement. We have in the past had a culture of complacency. We got very excited about thresholds and targets, be they of any lab value we could measure. We've had a number of negative clinical trials and endpoints and study design issues. And that, I think, thankfully is changing. That led, however, to a very large group of nephrologists who've been complacent, who are used to working in a knowledge void, and actually have started or thought to believe that they don't need to be involved in clinical trials. And patients have been very hard to recruit, and we've had to compromise study design in many ways. However, the good news is there are changes, and there are an increasing number of studies on specific conditions and a number of preclinical studies that are showing exciting molecular and other diagnostic targets and mechanisms that should give us great hope. And there are, in fact, more studies coming, and that is a real changing landscape as there are more compounds. And certainly we've got the recent wonderful stories of the SGLT2 inhibitors in kidney patients, specifically designed properly, as well as the new mineralocorticoid receptor agonists. Now we have biomarkers, genetics. We've increased our understanding of the value of biopsies for diagnosis, prognosis, and for identifying these therapeutic targets. And we have novel study designs, both available to us and other organizations, but really important that we embrace these new technologies and methodologies to really test all of our therapeutic strategies, do more clinical trials, have more opportunities, more targets, and really keep our eye on the ball. And recently, I was privileged to be able to lead an international consensus definition of clinical trial outcomes for kidney failure hosted by the ISN. And we actually have, for the first time, a consensus amongst patients, regulators, and trialists around a definition for kidney failure that we can actually appropriately put into and hopefully enhance clinical trial design. So how are we going to manage all the expectations of all these different people, patients, clinicians, the trialists, the regulators, pharma, basic scientists, administrators, and funders? I really think that is the million-dollar question, if you will. And if you think about the spectrum of chronic kidney disease, there are so many places where we can look for cost avoidance if only we address it this way and think about it always as a continuum and where we can actually spend our money and our energies the best. So early quality and diagnosis really very much depends on equitable access to screening and primary health care, reliable, essentially lab tests that I showed you before, well-trained healthcare workers, medication, affordability, and availability. And this is part of the HEARTS package for cardiovascular management in primary care, into which we actually do have some kidney perspectives. And if you think about public health and social successes, including improved drinking water, antiretroviral therapy, changes in education and fetal maternal health, and reducing poverty and increasing vaccination coverage, all of these are likely to reduce both acute kidney injury and chronic kidney disease if applied in a systematic and consistent way. And if we actually achieved each of the Sustainable Development Goals, we might improve not just the health of individuals, but from our perspective, kidney health. And that's what we're really here to try and do. So I think that to have an integrated approach to improve kidney health and really identify the gaps, we need better data with registries and economic impact, better research on all levels, and collaborative work both in and outside healthcare professions so that we actually model care and service delivery in a sustainable way. So ultimately, what I hope I've done is really helped us together to tip the balance towards better care, stress the need for more evidence-based and epidemiology to inform care, whilst acknowledging the diversity that all of us are living in, whether it's culture, resources, access to care and education, and to acknowledge all the different perspectives that need to be brought to this table. In answer to the question, what is the future of nephrology? I think it's a pretty exciting time to be in nephrology. We have basic science and translational consortia, patient-oriented consortia, and collaborative clinical trials networks ever growing in this space. That will lead to new knowledge, new paradigms, policies, and hopefully dissemination. And through that, I believe we really will achieve better global kidney health, which I think is good for all. So again, I'd like to stop there. Thank you for the invitation and your attention, and hope that together we can all close the gaps in care, research, and policy. Thanks so much for your attention.